I want to thank John and VJ for giving me the opportunity of speaking here in this wonderful setting. It's a real pleasure to be back at Whistler again and to see all that goes on here. My disclosures, and this is what I learned about multiple myeloma in medical school. One page in Cecil's textbook of medicine, and as many of you may recall, that book had 1,750 odd pages in internal medicine. Now, let us look at the last paragraph in a little more detail. The author states that the disease is uniformly fatal after an average duration of 2 to 3 years. He was a little generous in this estimate because at that time, the survival of multiple myeloma was scarcely a year. Then he goes on to say that Röntgen rays are advantageous in the disease, should be employed in all cases, and may even prolong life in some. That, with blood transfusions, is the only known therapeutic agent. Otherwise, the treatment is symptomatic. Well, shortly thereafter, 2 agents were introduced for the treatment of multiple myeloma, urethane and stilbamidine, based on a report of 2 patients. And stilbamidine was an extremely toxic drug and rarely used for multiple myeloma. However, for the next 15 years, urethane was the drug of choice, in fact, the only drug. And 15 years later, a randomized study was done comparing urethane with a placebo. And in this study, the placebo was cola syrup. And here we see the result. Not very good for 15 years of clinical effort. Now, let me go back just a little bit and tell you a few things about electrophoresis. It wasn't until 1937 that Arnie Tiselius reported that examination of horse serum showed 4 bands. This was determined by the old U-tube electrophoresis, in which proteins were separated on the basis of their refractive index. He labeled them albumin, which he knew to be present, and then 3 other bands, alpha, beta, and gamma. This paper was submitted to the Biochemical Journal and was summarily rejected. And so he had to proceed with publication in the Transactions of the Faraday Society, a journal which has long been out of print. Didn't work anymore. And there's a bit of a lesson here for all of us, and that is, if your manuscript is turned down by a journal, you should proceed to the next journal after making appropriate changes, or at least responses to the reviewers. Now, electrophoresis was not a test that could be done in the clinical laboratory. It had been recognized in 1939 that tall, narrow-based spikes were recognized in at least 2 patients with multiple myeloma. The problems from a clinical standpoint is that first, the electrophoresis instrument, the U-tube, cost $5,000. And secondly, it took one technician, one day, to examine the serum on one patient. So it was not very practical. A major breakthrough occurred in 1951 when Henry Kunkel was a postdoctoral student in the laboratory of Arnie Tiselius, and they utilized filter paper to support the serum of the patient, a solid medium, and this led to the common use of electrophoresis in the clinical laboratory. Now, I want to say just a word about Jan Waldenstrom's monumental discovery, one that is so obvious today that most people think that it was always been that way. And that is in his Harvey lectures, in which he discussed gammopathies and their abnormal formation. He came to the conclusion that there were 2 types of gammopathy. One, monoclonal gammopathy, which was either malignant, multiple myeloma, or Waldenstrom's macroglobulinemia, or potentially so in the form of quote, benign monoclonal gammopathy. The polyclonal increase in immunoglobulins, however, was a reactive or inflammatory process, and this occurred in patients who had chronic active hepatitis, rheumatoid arthritis, or one of the other collagen diseases. A concept so obvious today. And let's just perhaps listen to John Milton, who told us that so easy it seemed once found, which yet unfound most would have thought impossible. And many of you have seen things described in the literature, and you say, oh gosh, I've seen that I don't know how many times. But unless someone describes it, it's unknown. This is a photograph of Jan Waldenstrom, who used to come regularly to myeloma, monoclonal gammopathy meetings, and the like. Now, the next really major advance in the field was the introduction of L-sarcolysin by Professor Blokin from Moscow at the height of the Cold War. This agent, L-phenylalanine mustard, or Melphalan, or Alkeran as we know it today. This information concerning this drug passed to the West in 2 years later, 1960, at which time David Galton at the Royal Marsden recognized that this was an active drug in the treatment of multiple myeloma. And then in 1962, Danny Bergsagel, who was at MD Anderson at the time, treated 24 patients with multiple myeloma and reported that 8 of them had a very good response, something that had not been, that we had not, or had not been accustomed to in the past. Unfortunately, for the next 40 years, we made little progress. It can be summed up on one slide, as you see here, which is a large meta-analysis published by Keith Wheatley, in which he evaluated 20 randomized trials involving almost 5,000 patients, and reported that the response was indeed superior with any combination of alkylating agents, with a very impressive p-value there, but there was absolutely no difference in survival between the combinations and melphalan and prednisone. Furthermore, there were no subsets that showed benefit with the combination of alkylating agents. And we all thought that patients with aggressive myeloma would certainly respond better to combinations of alkylating agents. The next step was the introduction of stem cell transplantation by Tim McElwain, who reported a patient in the early 1980s with plasma cell leukemia who was given melphalan in a huge dose, as you can see here, 140 milligrams per meter squared. The patient did survive without any supportive therapy and had a good response. He then collected stem cells from the patient, and of course the patient relapsed subsequently, was given the melphalan plus the stem cells, and this time tolerated the therapy much better than the first time around. They also, in this paper, reported on 8 other patients with multiple myeloma who had received an autologous stem cell transplant. Following the introduction of high-dose therapy, thalidomide was introduced in 1999, and then bortezomib 3 or 4 years later, followed by lenalidomide. In the past year, 2 new agents, pomalidomide, a third level of an immunomodulatory agent, and carfilzomib, a proteasome inhibiting agent, were introduced in the U.S. for patients who had had 2 prior therapies with conventional therapy. Today, MLN 9708, NPI 0052, 2 proteasome inhibitors are moving along nicely. Elotuzumab looks promising. A large phase 3 study is ongoing. Bendamustine, a drug that was developed in East Germany during the Cold War because alkylating agents from the West were too expensive. And I would add that the expense of bendamustine today is extremely high. There are at least 50 histone deacetylase inhibitors, with vorinostat and panobinostat the furthest along. This is a study that my colleague Shaji Kumar reported. Almost 3,000 patients with multiple myeloma from our institution who were studied between 1971 and 2006. Those patients diagnosed before 1996 had a median survival of 2.5 years. those diagnosed between 1996 and 2006 had a median survival of almost 4 years. And then he updated our experience from 2001 to 2005, and again from 2006 to 2010, showing a better survival, a 5-year survival jumping from 47 to 66%. And I am sure that when he updates this next, that the curve will be even better. This is an exciting time in multiple myeloma, and I have been privileged to see this much progress over the past half century, and am eagerly looking forward to the advances in the next decade. Thank you very much.